Hi. All right, I'm going to start because I have clinic at 1, and I'm sure you guys do. So this was a part of the neurophysiology lecture that I was supposed to do a couple of weeks ago, but I couldn't do it. So we're going to be, my topic today is that somebody else here?
Yeah.
My topic today is about pain. So we'll be talking about the nociceptive receptors, signal transduction, distinguish pain pathways from the mechanosensory pathways. Did somebody speak about the mechanosensory pathways? The proprioception, touch? Not yet? This is supposed to be after. And then understand the pathway for visceral pain, referred pain, phantom pain, and then characterize peripheral and central sensitization of pain, as well as gain insight into some different aspects of modulation of pain perception. Okay, so this is like a basic neurophysiology lecture type of thing from your textbook, but I have put in a lot more clinical. I think that's more useful. So nociceptors comes from nocere, pain, that's Latin. Basically the pain is mediated by unspecialized free nerve endings that initiate the sensation of pain, and then the cell body lies within the dorsal root ganglion, like we all are aware for all sensory nerves. The cell body lies within the dorsal root ganglion. You have one distal fiber that comes to the limb or wherever, and then the proximal one that goes into the dorsal horn, posterior horn, right? So the athoraxonal process to the spinal cord or to the brainstem, depending on whether it's facial pain or axial or appendicular pain. Nociceptors are classified on the basis of their axons. So for the mechanosensory receptors, the axons are either, they're myelinated fibers, right, for the mechanosensory ones. So they're A, B fibers, and these are A2, but these are A delta fibers, which are myelinated, and then C fibers, which are unmyelinated. And because it's unmyelinated, the speed is much slower. It's just about 2 meters per second, whereas the A delta fibers are about 5 to 30 meters per second. So if you recall, if your mechanosensory fibers are much faster because they are thickly myelinated fibers. So those are the large fibers that carry your touch, your vibration, proprioception, those kind of things. So those travel at a rate of almost like 100 meters per second to 120 meters per second. So these are much slower compared to those because, either they're very thin myelinated fibers or unmyelinated fibers. The type of perception is again different. So the A delta carries either dangerously intense mechanical or intense thermal and mechanical. The C unmyelinated fibers are they call polymodal because they carry either thermal or mechanical or chemical, any of those. So there was an experimental demonstration in your book that basically says that the receptors are distinct for mechanosensory perception as opposed to pain, and stimulating the mechanosensory at higher frequency does not result in pain. Essentially, the pain fibers have to be stimulated for it to result in pain. There's also different class of these pain perceptions. There is a first pain, which is known as a sharp pain that is felt, and these are carried by the faster fibers, that is the A delta fibers. And then there's a subsequent pain. So this is basically a sharp first pain stimulus intensity is raised to a level that activates a subset of A delta fibers. So tingling at a lower level and sharp pain at a higher level. And then there's a delayed diffuse pain sensation that is brought on by the C fibers. Now, though the nerve endings are supposed to be free nerve endings, there are some receptors that are present, and you need to be aware of what these receptors are. They do like to ask about these specific type of receptors in your right exam, board exam, that sort of a thing. Okay, so these are basically called transient receptor potential channels. The subset of them is called the VR1, vanilloid receptor 1 and vanilloid receptor 2. So the vanilloid receptor 1 is present on both the C fibers as well as the A delta fibers. So both of them have the VR1 fibers, okay, receptors, and the VR2 is present only in the A delta fibers. Now the VR1 is stimulated by a variety of stimuli. So heat of 45 degrees or more, capsaicin, and the endovanilloids. So in response to tissue injury, you have some endovanilloids that are produced, and they can stimulate these vanilloid 1 receptor. The VR2 is present specifically, it is not stimulated by capsaicin. So this is stimulated by capsaicin. This is not stimulated by capsaicin, but heat can still stimulate it. Okay? I'm not sure how much of this, but they do like these receptors, especially with capsaicin, because we do use capsaicin clinically, right? We use capsaicin. Do you know of an indication where we use capsaicin?
Yeah, for pain.
Peripheral neuropathy.
For neuropathic pain, correct? So I'll be talking about it in the next slide. So primarily for capsaicin, they'll say it stimulates both the A delta and the C fibers, and it's mediated by the VR1 receptors, the vanilloid receptor 1. Okay, so that's the main take home from this. So these channels are basically like your other VGKC channel, like the voltage gated potassium channels or a cyclic nucleotide channel, and they have a pore between domain 5 and 6, which in resting conditions is closed, and when activated, opens up to release sodium and calcium and the action potential, like how you have for any of your other action potentials. So capsaicin, there was a specific write-up about the capsaicin. We discussed about the fact that it activates responses in a specific subset of C fibers, as well as the A delta fibers, which have the VR1 receptor. Okay, and repeated application of the capsaicin, what happens is it desensitizes those pain fibers and prevents endogenous neuromodulators such as substance P, which causes pain, VIP or vasoactive inhibitory peptide, which again produces pain, and somatostatin from being released. And that's how it's used clinically for preventing that sensation of pain. Okay, it seems to desensitize those pain fibers. So interestingly, this was just more for interest. I think if any of you have a fascination for, watching birds in your backyard or whatever. So birds don't have these receptors, but all mammals do. So you can actually lace bird seed with capsaicin and put it in your bird feed so that the birds can eat it and not feel the capsaicin, but squirrels do. I mean, I don't care if squirrels come to my backyard, but I'm sure people who are like avid bird watchers wouldn't want the squirrels to eat the bird feed. So that's an interesting fact. Okay, so
I have a lot of squirrels in my backyard. That's a good idea.
all right. So central pain pathways are distinct from the mechanosensory pathways. I think you've dealt with some of this as a part of your neuroanatomy lecture. You guys not so, but this is a pathway that you're pretty familiar with. So you have the dorsal root ganglion, and you have the dorsal root ganglion. You have the axon here, the central pathway and the peripheral pathway. So peripheral pathway is where you have these receptors, and the central pathway goes into your dorsal horn, and you have the laminae that are present here. So when the pain pathway goes into the dorsal horn, what happens to it? Does it go, what happens to it? It ascends up for a couple of levels, and then it goes into the synapse, which is the rexid laminae. And these laminae, again, they like these laminae. They want to know which are the laminae. So essentially 1, 2, and 5 are where these pain pathways go and synapse. Okay, that's something that they always like to ask. Lamina 2 is also known as substantia gelatinosa. That's something that they always like to ask in your writing exam as well. So 1, 2, and that writes 1, 2, and 5 is where they can synapse, and then you have the second order neurons that come over here. So these pathways now actually cross over to the other side, right? And then they ascend in the anterolateral column. Where does the next synapse occur? So these are the second order neurons, right? Where does the next synapse occur? The thalamus, right? Do you know what nucleus is the thalamus? So the next one occurs in the thalamus, and if it's peripheral, it happens in the VPL nucleus of the thalamus. If it is from the face, then it becomes the VPM nucleus of the thalamus. And then you have this go into the somatosensory cortex. Right? So now there is some modulation of these different pain pathways as it was along this path. So this is the same path that we described. The second order neurons go into the lateral spinothalamic tract via the brainstem all the way to the thalamus, where it goes to the VPL nucleus, and you have the postcentral gyrus or the somatosensory cortex. The same thing from the face. The face, however, is the trigeminothalamic tract. This is just a summary of the same. So for the face, you have sensory nerves that pain are 5, 7, 9, and 10. Right? Those are the sensory cranial nerves. They go to the brainstem via the cranial nerves, and the spinal nucleus of 5 is where they synapse for all of the bulbar pain, and second order neurons go into the trigeminothalamic tract to go to the ventral posterior medial nucleus of the thalamus. So there are parallel pain pathways that go through. Not all of them go to the ventral posterior nucleus. There are some other parallel pathways that are there which cause, so this is the sensory discriminative pathway where you can discriminate the pain sensation itself. But there is also an affective motivational pathway that goes parallel to this. So some of these fibers go, because there are other components of this pain, right? Some of them have pain that have an emotional component to it. Some of them have pain, so I'll put that in the next slide, right? The unpleasant feeling related to it, the fear related to it. So each of these components have, so like for instance, if it's the amygdala, it causes the fear component in it, of the pain. They say, oh, my pain is terrible, but I'm so scared of that pain coming, right? That kind of a feeling. So each of these have the affective motivational component, which can go through the reticular formation, superior colliculus at the level of the midbrain, periaqueductal gray region, which does have the opioid receptors, the hypothalamus, and the amygdala. And then there are some midline thalamic nuclei. So not all of them need to necessarily go through to the somatosensory cortex. Some of this goes to the insular cortex and the anterior cingulate cortex. So when it goes to the VPM and VPL, it's the localization of the pain pathway. So that's your discriminatory pain pathway. It hurts you, so you can pinpoint where the pain is, right? When it goes to the ventromedial nucleus of the thalamus and goes to the insular cortex, there is a painful and autonomic component to the pain. It hurt so much that I was sick, okay? Then there's also a mediodorsal nucleus that can go to the target region in the cortex is the cingulate gyrus. In that case, it becomes the emotional component of the pain. Okay, so also is the amygdala. This pain gets me down, or I'm so scared of this pain. And then there is a reticular nucleus in the thalamus where this pain pathway can go to, and then it projects basically diffusely to the cortex, which leads to an alerting response. The pain hit me, and I was suddenly awake. That's that sort of a component. So these are pathways that run parallel to the main discriminatory pathway of the pain. This is something, again, for you to know that it's there. I don't know how much they'll ask you about it, but it's interesting to know that there is this parallel pathway that comes in, which gives you the affective component of pain. Then, this is the same thing. There is also some modulation of the pain. There are some descending pathways that modulate the pain, both at the level of the thalamus and beyond. So the somatosensory cortex sends messages to the amygdala, to the hypothalamus, and the midbrain periaqueductal gray, and it sends information through the other nuclei to modulate the perception of the pain. Okay. Then the concept of dissociative sensory loss, I'm sure you're pretty aware of this. So dissociative sensory loss is basically you have the mechanosensory pathways. So in this pathway that we discussed earlier, mechanosensory pathways have a similar projection. You have the dorsal root ganglion, peripheral, central, but the only thing is at this, for this pathway, the neurons travel all the way to the top ipsilaterally, and they only cross over at the level of the medulla. So at the level of the medulla, right? So up until there, it's all the same. So when you transact a particular say for instance you're catching wherever, so you have these different pathways that go through. So if you have a lesion, say somewhere over here, the contralateral side of the card, right? So you have the similar pathway that's coming from the dorsal part. This is mechanosensory. So when you transact under the card, you have a lesion of the card over there, it causes ipsilateral loss of touch and contralateral loss of pain, right? The same concept is applied for patients who have, say, a syringomalia, because the syrinx is located right here around your central canal, and this is where the crossing fibers are. So it catches these fibers but does not catch your dorsal column fibers, right? So they can have a dissociative sensory loss. Then visible sensation. What about visible sensation? What is it carried by? So the visible pain sensation, interestingly, is carried by a pathway that is similar to your dorsal column medial lemniscus system. It is not like your peripheral pain sensation. Okay, so the visible pain sensation is essentially like when the viscera expand, say the ureter, because it has a kidney stone in it, right? So those kind of pain is carried by a pathway very similar to the dorsal column lemniscus system. So it goes to the spinal cord. The second order neurons are only at the level of the medulla, at the level of the gracile nucleus and the cuneate nucleus. And then you have the second order neurons cross over at that level and go further up. There is something that was described, a surgical transection of axons that run in the medial part of the dorsal column, results in significant relief of debilitating pain from visceral cancers coming from the abdomen and pelvis. So that's how we know that those are the pathways. It's not the anterolateral system, but it's actually the dorsal column system that carries the visceral pain. Okay? Then the concept of referred pain. So referred pain is basically when a pain is referred to a structure that develops from the same embryonic structure. There's a couple of theories that look at it. One is that the afferent nociceptor, you have the somatic structure and then you have the visceral structure. They both converge on a particular second order neuron, and that's why when you have a viscus that is painful, say for instance it's the cardiac fibers. We know that the referred pain is along the medial aspect of the arm. So the fibers from the cardia as well as the fibers from the medial aspect of the arm, they both converge on, this is what, T6, right? C6. So they both converge on that particular dorsal horn. So when this pain goes up to the dorsal horn, it seems to send some kind of a reciprocal innervation to the same pathway. So that is one of the theories. The other theory is that they both have collateral pathways. So essentially, I don't think there's much of a distinction, but they both share a common pathway where the second order neurons form, and that's how the visceral pain is referred to a peripheral somatic structure. Okay, so there are some examples of referred pain, the cardiac pain that we discussed. If it's esophageal pain, sort of along the torso, ureteric pain, because we know it's from loin to groin. That's the classic description, and prostatic pain. So some of the visceral pain, we do know that there are clues that come from, because there's a classic referred pain that comes through. Where did it come from?
Just now, like Sheila came on here.
Oh, Sheila, I didn't see her. All right. Then there is some sensitization. There's a concept of sensitization. So there are some people who have this pain. There's an increased neuronal sensitivity, is basically sensitization. So there is the sensation of hyperalgesia, where a stimulus that is slightly painful is sensed as being extremely painful. So what happens to that? Like for instance, increased sensitivity to temperature after a sunburn, right? So there are two different types of sensitization. One is peripheral sensitization and one is central sensitization. The peripheral sensitization occurs because there's an inflammatory soup. There's a whole release. There's some kind of an initial tissue injury there, and there is a release of substances like the CGRP, the substance P, and then a lot of these prostaglandin-related neurochemicals. The primary idea of this is basically to protect and promote healing and guard against infection, but then that also results in the effect of increased sensitization of pain. So that's the peripheral sensitization. And then there is central sensitization. There's two different components that are explained. One is allodynia, which is transcription dependent. So allodynia, do you know the distinction between allodynia and hypersensitivity? Hyperalgesia.
Hyperalgesia is when you have increased sensation of pain due to a painful stimuli. Allodynia is a sensation of pain with normal stimuli.
Normal stimulus, correct. So now allodynia is a central sensitization. So hyperalgesia seems to be a peripheral sensitization. Like for instance, in people who had, like sunburn was the example that they gave, but the other examples is patients who have like the reflex sympathetic syndrome. That also seems to be related to this hyperalgesia. The allodynia is when there's an innocuous stimulus to the skin, and that results in increased perception of pain sensitivity. So this results from long-term potentiation. There's increased activity in the nociceptive afferents, and then action potentials in the dorsal horn and pain sensitivity. We don't quite know why that occurs, but that occurs and results in allodynia. The other phenomenon is known as a wind-up phenomenon. It is transcription independent. So basically there's an increased rate of discharge of the dorsal horns with low frequency stimuli, low frequency painful stimuli itself. So these are again more of terminologies. I don't know how much in the clinical reference, but you just have to know that one of them is transcription independent, one of them is transcription dependent, and they both result in central sensitization of pain. A couple couple more concepts. This one is neuropathic pain. So you do encounter neuropathic pain a lot in the clinical setting, right? So as injured tissue heals, there's sensitization induced with peripheral and central mechanisms, and the pain threshold returns to pre-injury levels. But then when the afferent fibers are damaged themselves, then that results in a central neuropathic pain. So there are different clinical scenarios, like we've seen trigeminal neuralgia results in neuropathic pain, post-herpetic neuralgia, peripheral nerve injury pain, either surgery or compression. For instance, you have median neuropathy, or trauma, post-amputation pain, polyneuropathy as a result of ischemic injury to the nerves, right? So these are where the nerves are actually injured and result in pain, okay? For the trigeminal neuralgia, either it can be idiopathic inflammation or because of compression of the nerve that results in inflammation, right? And then, of course, radiculopathy, again, because of compression of the nerve, either because of some kind of a bony spur or maybe the disc bulge. Then at the central level, you can have neuropathic pain that's associated with spinal cord injury at the level of injury or below the level of injury. Post-stroke pain, which results from, say, thalamic stroke, right, or in lateral medullary infarction. And then a combination of these two. So these are some examples of neuropathic pain. Here, there's actual damage that exists to the neuron, which could be central or peripheral, that results in pain. Then the concept of phantom pain. So phantom pain is typically described in the setting of amputation of an extremity. There's an illusion that the missing limb still exists, although it is not there. There are some theories as to why this occurs. One is central changing. There is sprouting of the nerves. There's general disinhibition, and some kind of map remodeling that results in it. And peripherally also, there seems to be some disorganized transmission. Although the nerves don't exist, there are the proximal input from those nerves that are there that result in the phantom pain, which I think is very difficult to treat. Then the last couple of concepts that the book spoke about are the placebo effect. So placebo means I will please. So it's a physiologic response following the administration of a pharmacologically inert remedy. There were sedative effects that were described in more than 2/3 of the people who took a placebo, and stimulant effect as well. 1/3 had headaches, dizziness, tingling of the extremities, staggering. So it's not really, the placebo effect we believe is real. It's not just an imagination, because we know that, acupuncture, anesthesia, or analgesia through hypnosis also seems to work. I just found this cartoon hilarious because I'm sure this is something. Anyway, the last concept that the book spoke about was the gating theory of pain. So when you have two fibers, like the dorsal column, you have both the C fibers and the A beta fibers, which is your mechanoreceptor fibers. So when they both are going through the same dorsal horn, when the A beta fiber is stimulated, first of all, it's faster, right? So those are the ones that are thickly myelinated. They seem to go faster, and they seem to inhibit. They seem to have an inhibitory local circuit that inhibits the C fibers. So for instance, when you have pain, you bumped your toe somewhere, when you have pain there, your natural instinct is to go block that pain by pressure sensation. So the pressure travels faster and blocks this pain. So decrease sensation of the sharp pain by activating the low threshold mechanoreceptors. So this is all the book had. I'm just going to go over to some questions. You can start with.
A lesion of the spinothalamic tract in the mid-thoracic level will produce which of the following findings? Lesion of the spinal tract. Ataxia of the contralateral leg, loss of pain and temperature of the ipsilateral leg, loss of pain and temperature, sensation in the contralateral leg, loss of pain and temperature in both legs, or loss of vibration sense. So spinothalamic carries your vibration temperature, so it should be mid-thoracic level. What's the pain and temperature loss in mid-thoracic? So ipsilateral.
Ipsilateral.
The Would it be ipsilateral or contralateral?
Contralateral. Because it's
Contralateral, because it's the spinothalamic tract, right?
Okay,
So
it's
pain and temperature in the
decussate.
contralateral, right? So loss of vibration sensation in the ipsilateral right, what is it? Same question saying lesion in the dorsal column of the mid-thoracic spinal cord will produce ipsilateral loss of proprioception and vibration, contralateral loss of pain, temperature, sensation. So the axons, we know the mechanism, right? Which of the following lesions?
Which of the following lesions may result in loss of cutaneous nociception? A, sensory ganglionopathy. B, a tumor that involves the intermedial lateral column. C, a glioma of the hypothalamus.
The intermediate
D,
lateral column is basically that inhibitory pathway that lies sort of right around here. That's the intermediate lateral column.
D, B12 deficiency. E, an anterior pontine demyelinating lesion.
Loss of cutaneous nociception.
C and A delta fibers. So,
Which are the ones you can take out from here?
B, B12 causes subacute complication.
Yeah, it can produce, but
Since you can get sensory neuropathy.
only one of them.
Only one of them can be the answer.
Correct.
Sensory.
That is true. So which one?
Sensory.
Steven. Okay, rule out the ones. Can it be an anterior pontine demyelinating lesion?
No.
No.
Anterior is motor.
Motor, yeah.
So that's out, right?
Right.
Can it be B12? Can be,
Can
maybe,
be.
if you're thinking, subacute combined, dorsal column, lateral column, maybe. Okay, so let's keep that there. A glioma of the hypothalamus?
No.
Probably not. It does involve the pain pathway, but it's more of the modulating perception of pain. Tumor that involves the intermediate lateral column?
No, because it.
Possibly not.
That's a sympathetic.
Yeah,
Yeah,
that's a
yeah.
sympathetic pathway.
So
And what about a
A.
sensory ganglionopathy? So
maybe.
what is this?
Dorsal
Yeah.
ganglion.
Sensory ganglion. So do you think the sensory ganglionopathy
Yeah.
can result? So that's the answer.
Yeah.
Okay, I know, but the question, so these are all, they'll design your questions around this topic, I think. So, basically,
Oh,
Same
B12 is large
discussed.
fibers.
now, Marie.
55-year-old man has severe pain and gentle touching of the arm. 6 months ago, the median nerve was damaged during creation of an anterovenous fistula for dialysis. Which of the following terms best describes this phenomenon? Hyper. B.
B.
A.
How many
It's
of you
gentle.
go
Where
with
is it? Oh, gentle. Then, yeah, A.
A? So allodynia, right? So
Allodynia.
the question says gentle touching results in pain, and that's allodynia. If they said, mild noxious stimulus results in extreme noxious pain, then it would have been hyperalgesia, okay? An increased perception of painful stimulus. Allodynia is an altered perception. Gentle touch results in pain. So is this a peripheral mechanism or a central mechanism?
Central.
And what are the mechanisms that we discussed? We spoke about 2 specific mechanisms. So allodynia is one thing, right? So allodynia results from long-term potentiation of the same fibers, okay? And that's transcription dependent. The other mechanism that can result in a similar perception is called the wind-up phenomenon, that is low-grade stimuli that's applied that results in increased perception of the pain itself, okay? So it's not hyperpathia, hypersensitivity, hyperesthesia.
All right, 25-year-old janitor has severe back pain and is unable to stand up straight after he fell at work. On physical examination, he has positive pain behavior but no neurological deficits. A surveillance video from the insurance company shows he continues to play baseball with friends.
I was thinking it's an appropriate question for you.
Which of the following is the most likely diagnosis? Conversion, factitious, hypochondriasis, malingering, somatization. So conversion is manifesting signs, right? That there's no mention of this here.
Yeah, there's no manifestation, there's no neurological deficits except that there's pain, okay? Yeah.
Hypochondriasis, we're speaking about someone with multiple concerns regarding somatic preoccupations.
Correct.
Okay.
He doesn't seem to have that
He doesn't seem,
either.
there's no mention of that here. Factitious disorder is someone intentionally trying to get a secondary gain from a pathology that's not there. I guess I can say it that way.
It's primary gain, isn't it?
But was that the,
Yes, secondary gain. should be-
because
Malingering.
malingering,
Mhm.
Like
Factitious.
they just wanna be sick.
Okay.
Right.
Right.
Factitious is where they have a primary gain.
Right.
Malingering is where they have a
Same thing, secondary.
secondary
Secondary
gain.
Mhm. Okay, and then somatization disorder with psychological factors. I don't know, someone help me with that one.
I'm not sure. It's one of those options.
Okay, so I would say this is malingering.
Likely malingering, right? Because again, it's the insurance company that seems to find it, and he's saying that he fell at work, and that's what resulted in this. So I think malingering would be the right answer. Though you can get confused between some of these, but I think that's why I said you would be the right person to get this question explained. So essentially, it's not hypochondriasis and not conversion disorder. It's not fictitious. It seems to be more of a secondary gain related to the fact that he fell at work. So I would probably call it malingering. Okay. Which of the following receptors mediates the wind-up phenomenon? I'm not even sure I know the answers.
Vanilla.
I don't think I put the answer for this
Ah.
either. I was like, I created a slide like a few days ago when I was supposed to talk to you guys. So let me pull up that slide again and see if I spoke about it. Removing the magnesium block of the NMDA receptor is supposed to result in the wind-up phenomenon. Okay. So wind-up, like I said, is the increased discharge of the dorsal horn from repeatedly low-frequency activation of the nociceptive efferents. It's a summation of all slow synaptic potentials in the dorsal horn that results in a sustained depolarization. It's dependent on the voltage-dependent L-type calcium channels, and removing the magnesium. So basically, you know that there is a magnesium that blocks the NMDA receptor, right? So when you remove that, that results in the glutamate receptor activation. NMDA is one of the type of, it's a type of glutamate receptor, right? So that's what results in the wind-up phenomenon. I didn't touch upon it, but I forgot that I put a question on it. There we go back. And I think that's it. It's a pretty short topic to talk about. And let's talk, I think,